So what I did was basically cliff notes so that you don't have to read the article to pass the test. You can just look over the 1 or 2 pages of outline notes that you've got on the CD, right?
No, just the handout.
Okay, in the handout. And the bold stuff, this is the items you really need to pay attention to. Okay, so I got the opportunity to review Meg Urbain's article about the role of hyperinsulinemia, euglycemia for beta blocker and calcium channel blocker toxicity. And this is a review paper. So the authors start out introducing the importance of toxicity from these classes of drugs. They explain there's a little bit of difference, even though we often lump these two classes of drug toxicity together, the mechanisms are a little bit different. And they review the fact that calcium channel antagonists inhibit calcium influx into myocardial cells via the L-type channel, or the voltage-gated calcium channels, which we've sort of ignored this weekend. Beta blockers block the beta-adrenergic receptor and in some cases inhibit sodium channels. They review the hallmarks of clinical toxicity, namely hypotension, bradycardia, bradydysrhythmias, and pump failure. They also briefly mention other system abnormalities, including mental status, findings, seizures, respiratory failure, and they spend a fair amount of time talking about the diabetogenic effect of these drugs under the rationale section for using high-dose insulin. Okay, so let's set the stage for high-dose insulin. These drugs, and this is true for both calcium channel blockers and beta blockers, change the heart's energy substrate preference from free fatty acids, which it likes to use during the resting state, to carbohydrate dependence during stress or shock states. And in addition to that, calcium channel antagonists inhibit insulin release. So we have a metabolic state where the heart needs glucose, which the liver provides, but it can't really use it because there's a relative insulin lag. And in addition, calcium channel antagonists also inhibit mitochondrial enzymes that help convert pyruvate to acetoacetate. So instead of making another energy molecule, pyruvate is instead converted to lactate, and lactate accumulates. Okay, so anything in orange is going to be one of those important things that I think you'll probably see on the test. Okay, so why should insulin work? Well, you have a metabolic state where you need glucose, you don't have enough insulin, so if you give exogenous insulin, you'll allow maximal myocardial utilization of the preferred substrate during stress. And as an added benefit, you'll convert lactate to pyruvate to acetoacetate, so you have an additional source of energy molecules. And this will increase myocardial contractility without increasing work of the heart. And he spends a little bit of time contrasting high-dose insulin to conventional antidotes, which tend, although there is some benefit, they tend to increase free fatty acid utilization, and that's associated with increased energy work. He goes on to review several benchmark research studies, and the most consistent finding from all of these studies is that there's increased carbohydrate utilization with increased contractility, and if you increase contractility, there's very good survival in the animal models. And at the time this was published, he collected 15 cases that were in the literature, and again observed that the most consistent finding in these clinical cases was an increase in blood pressure that occurred roughly 60 to 90 minutes after high-dose insulin was started. There was also no consistent effect on bradydysrhythmias or bradycardia. And because of the time that they saw the blood pressure rise, he raised the question of, wow, was insulin started too late in these cases, and should it be started earlier? And he kind of glossed over potential adverse effects of high-dose insulin therapy like hypokalemia and hypoglycemia, and said these were easily addressed or prevented. So his conclusion regarding calcium channel blocker toxicity is that high-dose insulin is not necessarily the first-line therapy, but should be a fairly early adjuvant treatment when conventional vasopressors fail. He went on to review, in similar fashion, high-dose insulin therapy for beta blockers. He reviewed several studies whose results mirrored that seen in the calcium channel blocker animal studies, that high-dose insulin improved substrate delivery to the heart, improved contractility, blood pressure, and with those changes saw increased survival. At the time this paper was published, there was no cases in the literature, no human cases of high-dose insulin for beta blockers, and he simply states that needs further clinical study. Okay, his overall summary for high-dose insulin therapy showed that insulin improves inotropy during drug-induced shock. It has the added benefit of reversing acidosis. It may increase responsiveness to catecholamines. I kind of think that conclusion was a little bit of a stretch because the studies really don't show that. And then lastly, the requisite statement that this needs further study. Okay, well, this study was published in 2004, so a little bit has gone on since then. One is some elegant mechanistic work from our colleagues at UVA who's shown some additional insight into how calcium channel blockers and insulin affect metabolism. And we now know that calcium channel blockers inhibit glucose uptake into the cells via phosphatidylinositol-3 kinase. I can't believe I can say that tongue-tied. And that insulin therapy restores PI3K function. And lastly, we want to ask the question about these articles. Will Megarbane's article stand the test of time? And since 2004, there's been about 70 cases of calcium channel blocker, combined calcium channel blocker, and an isolated beta blocker toxicity that have utilized high-dose insulin. And overall, that additional case experience is associated with 87% survival with obvious limitations, making conclusions about survival and case reports. The range of insulin used has widened since Megarbane's paper. But I think this experience generally supports the author's conclusion of very early high-dose insulin usage, especially if you can demonstrate depressed myocardium. All right, so if you were daydreaming about whether you're going to have a mojito or a Mai Tai out by the poolside bar, here are the 5 key concepts, plus I threw in a 20% bonus, so 6 key concepts. So high-dose insulin allows the heart to utilize the desired substrate to make energy and support the heart during shock. It also can convert lactate to pyruvate, which is an additional energy substrate. The overall effect is to increase cardiac contractility without increasing work. And this increased contractility is probably what confers survival on this therapy. The most consistent clinical finding was an increase in blood pressure about 60 to 90 minutes after starting high-dose epinephrine that allowed you to wean vasopressors. And it's not the first line, but a fairly early adjuvant treatment when conventional vasopressors fail. Now, if you have trouble with the test, I'm going to totally blame this on lead neurotoxicity since I'm a child of the 50s, albeit late 50s. I'm a child of the 50s. Any questions?